So tonight we're going to be looking with the theme we will be looking at for this week is going to be mental health, which usually falls in the last week of the sort of towards the end. But this time we've had a bit of a scheduling challenge, and therefore I'm very pleased that we're actually starting for a change with mental health right at the very beginning. And generally, if you go and look out for webinars around mental health issues, this is an extremely neglected area. And it's interesting because if you look at the amount of patients that you actually have in your facilities that struggle with chronic mental disorders, it's quite a substantial amount of people that come through your OPDs and come through your hospitals. And yet the amount of attention and time we give to it within webinars, within guideline developments, within trainings are sorely lacking. And that's largely to do with that there's not nearly the funding that there needs to be. It's not quite as, I don't know, sexy a field as HIV or diabetes or pre-exposure prophylaxis or some of these, especially the communicable diseases, has been taking a large share of the resources. And what we have done in the last two rural onboardings, I think we covered mood disorders in one of the ramp talks where we talked about distress specifically. And I think at the last rural onboarding, we actually covered chronic psychotic disorders. And so I decided for this year, we need to actually talk about bipolar. I don't know when last any of you have attended a talk on bipolar disorder. And in the ideal world, if you look at bipolar also within the DSM, you would normally say if you see a patient where you're suspecting bipolar disorder, ideally they should be referred to your amazing local mental health discipline, a multidisciplinary team, which should have a psychiatrist, a social worker, a rehab team, and a whole support structure to support the family and this person throughout their life. And the challenge is you don't have that. So most of you sitting out at a district hospital or a rural facility is not going to have a full disciplinary team that's going to help you look after your patients with chronic psychotic disorders. And this means that your team has to do the job. And I think one of the challenges is that because things, especially bipolar and schizophrenia, can be quite hard to diagnose and make that diagnosis. Quite often what we do is when we see these patients, they become the famous, known psych patient, where you sort of do the minimum you can. It needs to be happening. Do your repeat script, do a little bit of advice, remember to do that permanent grant, hopefully, and move it on and hope the next person knows what's going on. But the buck stops with you. And what I really want to encourage you to be able to do after this presentation is diagnose, make that diagnosis, put your head on a block, tell the patient you have bipolar 1 or bipolar 2 disorder. And if you've made the diagnosis, to actually have a plan on how you're going to manage that patient and to accompany that patient with this illness. So first, we're going to just look at a little bit of an overview of bipolar, and we're going to talk about terminology. So in psychiatry, you don't do blood tests, remember, to diagnose anything. So there are various symptom complexes that we look at, and you have to understand the symptom complex if you want to be able to diagnose the illness. So we're going to spend a little bit of time on that. And of course, when we talk about bipolar, we're talking specifically about abnormal mood changes. So it's actually very different from depression, where depression is that you're constantly sitting sort of below par. The issue not here is the fact that you go high, but the issue is that you fluctuate. So sometimes you are below, sometimes you are above, and that middle button is simply not working. And depending on the data you look at, it can be anything bipolar 1, between 0.8 and 2.4% of the population. Bipolar 2 is actually more common and maybe also more missed, up to 4.8% in some of the data. And it's pretty much equal in males and females, but quite often men tend to present with mania early, more often in their first episode. And therefore we miss it more often in women because their first episode was quite often as a depression. So remember, this is largely a genetic disease, so it starts when people are quite young, and it has this chronically relapsing course. It's not something that's going to burn itself out. Major depressive episodes is obviously a symptom of both bipolar disease as well as major depressive disorder. And therefore, 69% of our bipolar patients are usually misdiagnosed. So normally you meet them in the depressive phase. They might never have had the manic phase yet, or you might not be aware that they've been hypomanic in the past, for example. And so quite often we treat them for depression, and the depression ends up being very resistant to management, for example. And of course, to define something as bipolar, they must have had either manic or hypomanic episodes. And it depends on which ones you've had and how they change. That's going to make us decide what kind of bipolar disorder they are. And we'll cover that in a moment. So also same, we talk manic depressive disorder is all old terms for bipolar. So very important, it's genetic, and there's actually a high genetic risk, an overlap with both depression and schizophrenia. And if you've got a first degree relative with bipolar, that definitely increases the risk that you might have bipolar. But there's very particular things, and we're not sure if it just helps it manifest earlier or makes it manifest more severely, or whether it's very difficult. It's not the kind of thing you can do an RCT on. Would your bipolar not have manifested at all if these things didn't happen? We don't know, but we definitely know that there is a relationship between regular substance use and particularly cannabis, interestingly enough. So if you're using cannabis regularly in the week, you might have a predisposition. They might trigger bipolar. So interestingly, there's actually been a particular link with war and trauma and stress, particularly in young children. So parental loss before the age of 5, for example, has been linked with it. But TBI, traumatic brain injury, is also a risk factor for actually having bipolar. And in that scenario, you might see it later in life as well. But very important, there's definitely to do something with pregnancy. So hormones can have an effect on this. And there's a few things that seem slightly bizarre. So flu in your 3rd trimester of pregnancy might trigger it. Smoking during pregnancy, another bad thing that smoking can do. But in pregnancy, any drugs, especially anything related to either the opiates or the stimulants or even sedatives, can potentially trigger episodes within pregnancy. And then, of course, there are some factors that just makes the whole thing worse. So if you're using substances, and quite often these episodes, one self-medicates with substances, and that's just going to complicate the whole thing. Any anxiety disorders is going to make it more complicated. Socioeconomic problems in itself worsens these episodes, but there's also been links to child abuse, sexual maltreatment. All of these things can make this precipitate these episodes. So with pathophysiology, I get very bored with pathophysiology. The important thing with pathophysiology is the fact that the button doesn't work. So it's not just simply about serotonin transport issues like we're seeing in depression. It's something to do with the dysregulation between the excitatory and inhibitory neurotransmitters. So this thing of not being able to stay on the level, but going either high or going either low. And that is why we don't ever treat the major depressive episodes in bipolar with antidepressants on its own. That is potentially problematic. So let's just look at some of those definitions and terms that I've talked about. And at the moment, we're going to just look at what we call episodes. So before you put something into disorder, you first have to define the episodes, and then depending on the length and number of episodes creates the disorder. So major depressive episodes we use in both bipolar and MDD. And the important bit here is the length of time. So at least 14 days of those classic symptoms that we always ask about in our PHQ-2 and PHQ-9s. A manic episode, interestingly, there has to be symptoms for at least 1 week. So if you have somebody who's been very high for a weekend, for example, after taking various concoctions of drugs, that would qualify as a manic episode. You just help here with somebody's muting. Okay, there we go. And important with manic episode, and we'll talk quite a bit about the symptoms, don't stress about that at the moment, is mostly these patients need to be hospitalized. So a hypomanic episode is like the manic light. And usually they are not required to hospitalize. That's almost the major way in how you differentiate between these two. It's briefer and it's less severe. And to qualify as a hypomanic episode, you need to have had it for at least 4 days, but we will look at that in some detail. So this is the actual DSM classification for the episodes. We're not yet a diagnosis, and they've even got a nice mnemonic. I wouldn't worry about this. You guys know depression backwards. PHQ. So for those of you who go PH wide, please go and Google it. There's something called the PHQ-9 and the PHQ-2. It's the Patient Health Questionnaire. And it's basically 9 questions you can ask with a nice scoring system. It's based on the DSM and it can help you make both the diagnosis of a major depressive episode and also classify it as mild, moderate, or severe. Manic episode. Okay, so now here let's get into the details of what do we mean when we say somebody is manic. And there's a classic triad. There's basically three things that we need to see. The first is heightened self-esteem. So they have this extraordinary, amazing feeling about how awesome they are, which is very lovely, and problematic from not wanting to get treatment, for example. The second aspect is increased motor activity. So this means busy, active, getting things done. And it's always accompanied with quite a lot of energy and potentially agitation. And then the third triad is that you can actually see this energy and this activity and can see what's happening in their brains by the way they're talking, and you get this pressured speech and fast speaking. So usually manic episodes are very obvious and outrageous. You're not going to miss it. It's not one of those things that you're going to go, oh, just this guy normal, it's just a bit eccentric. No, you're going to notice something's not right. But what does happen is that quite often it might get confused with schizophrenia. So people can get to the point where they're quite manic with this, where they're quite psychotic with their manic episode, and then it's quite difficult to tell them apart. Manic episodes are actually much less common than the major depressive episodes. Again, we're not talking about disorders yet. Yeah. Let's start actually just looking at the criteria in terms of how we put that together. So this is the DSM criteria for the actual manic episode. And again, that's where that 1 week comes in. So you have to have had an abnormal mood for that 1 week. Remember, we talked about that increased feeling of awesomeness. And this mood of yours is elevated, expansive, or irritable. And that I want to emphasize. So not everybody is necessarily happy. They can also be extremely irritated. And the second factor, they must have persistently increased goal-directed activity. And in the beginning, actually, they get quite a lot of stuff done. So it's not like it's random, disorganized behavior like we see in schizophrenia. They want to do something and they're getting on and getting stuff happened. And then the last criteria is to do with sort of these various manifestations of being manic. They've got the dig, fast, mnemonic, and you need to have at least 3 of these for it to qualify as a manic episode. If they're not elevated, if they're just very irritable, then you need 4 of these. And we can just quickly look at those because that's quite important. So they have to be distractible, easily distracted by everything around them. They have to have little sleep. So that's it's a good indicator that something's not right if they're needing less and less sleep, but they're not tired at all. They have this grandiosity, this heightened self-esteem, and in a manic people, quite often this can be delusional, and they can even have delusional ideas about who they are and what they can do. A flight of ideas, so ideas flitting from one place to the next, having lots of activities with plans and energies and things they want to do. We mentioned that rapid speed. So when you're having a conversation with them, it's quite difficult to interrupt them. You sort of can follow their train of thought, but they quickly flit from one thing to the other. And then the real worry and the real concern with manic episodes is what they call your thoughtlessness, and is about the loss of judgment. So the challenge is that they have no insight that this is what's going on, and they feel awesome. And this is a very lethal combination. And they can make all kinds of decisions during this time because they're actually still quite functional, especially early in a manic episode. So they can spend money on all kinds of things. They can have indiscreet sexual liaisons. They can do things in public that's quite inappropriate, and do this with an extraordinary amount of confidence and happiness. So when we think about, quite often when we think about mania, we just think about, whoa, happy person. And in beginning, yes, they can have quite good humor, they can be quite funny, they can be quite entertaining. But as the mania actually worsens, it becomes sort of less cheerful and becomes more of a driven, and it's not funny anymore. So if somebody's mood is actually making you feel slightly unsafe and is making you feel uncomfortable, that mania has already been progressing. So we've mentioned that sometimes they might only be irritable. And that can confuse the diagnosis. What can also be a bit puzzling is they might be very manic, and then suddenly they sit in the corner and crying their eyes out. So you can have this funny little micro depressions, and it's almost this over intense emotions that come to the surface. And what makes it very confusing is that, of course, they become very impulsive when they're manic. And so alcohol and substance use often accompanies the episode, and that can really confuse it. If they don't have a previous history, you're going to go down the route of a substance-induced psychosis potentially. So the DSM feature, to be able to classify it as a manic episode in terms of differentiating it from hypomania, which we'll talk about in a moment, is it must wreak havoc on the lives of patients. So they're not able, as they become worse and worse mania, they become less able to focus attention. They can't actually do all these things they want to do, but it starts straining stuff. It starts making trouble. So it starts straining relationships. Quite often they get into arguments because people are also trying to contain their behavior, can lead to all kinds of awkward sexual entanglements, which can lead to disease, divorce, or unwanted pregnancies. And of course, once they've come down, they now have to live with the consequences of what's happened while they are high. So there's a natural, important need for everybody around them to try and protect them. But because they don't have any insight, that can cause an extraordinary amount of conflict and tension. So to be able to call it mania, there has to be this functional effect of the illness. So very important, we can't call it manic episode unless we have excluded other things, that it's not hypothyroidism, for example. We need to make sure they're not actually on amphetamines or something. And then it can be confusing things like schizoaffective disorders, which we're not going to discuss here. That is psychiatrists you're going to need to help you make that diagnosis. Your neurocognitive disorders, your ADHDs, perhaps not so much for mania, but certainly for hypomania, that can also be difficult to sometimes differentiate. Great, so that's mania. Mania is quite easy. Hypomania gets more tricky, and this is sort of mania light. So again, there's a high mood, either high, expansive, or irritable again. And there's definitely also this increase in energy and activity now. So they're full of plans, they want to get things done, but they actually get stuff done, right? Most productive they've ever been, gosh, my goodness, house is suddenly, they've decided to build a new extension, and they've decided to put out a new deck, and they've decided to fix some stuff, and it's all very lovely and everything's happening. They have to have had this for at least 4 days. So this is not a day or two of hyperfocus. There must have been at least 4 days of this episode. And then again, there are at least 3 symptoms of this particular list. And it's very similar to the mania, but I'm going to show you in a moment what's different. And again, if they're irritable, then you want a few more of these to confirm that it's hypomania. So they also sleep less, just like the manic patients. They have this increased level of activity. And sometimes it can border on the point of agitation. So they're trying to get things done. They get frustrated, especially if things go wrong. Judgment's not great. And the problem is they're not psychotic quite, but there is a little bit of a challenge because they don't have insight in what's happening. So they're going to spend more money than they actually have. They're going to get entangled in stuff they probably shouldn't be doing. It might not be as explicit as in mania, but there's quite a lot of bad judgments that can happen during this time. They can also have this very fast, quick way of talking, flight of ideas, talking about this and talking about that, easily becomes distracted. And then they also have this heightened self-esteem, but it's going to come across as being very confident. They've got stuff they know, they've got amazing ideas, they feel great about themselves, but it's not to the point where it's delusional. So if you want to know, is this manic or mania or hypomania, these patients are never psychotic. So they're never going to have an actual delusion that you are having. And so therefore, hypomania would not need admission. And if they do need admission, then you're probably talking more about a manic episode. So even with the judgment stuff, you can negotiate with them, for example, in terms of things like spending money and some of their behaviors. So they're still able to engage. So that makes it very difficult, because what will make a family member, because they're not going to come to hospital, what's going to make a family member decide to bring the patient to hospital? And quite often people will have a hypomanic episode and sort of come out of the hypomanic episode and nobody would have been the wiser. Now they might present later on with a depressive episode, and if you do not think to ask, nobody might even realize that actually they've already presented with bipolar earlier. So this is just a nice table that compares the two. Those of you that are very new to it, so remember, manic episode, you must have at least 1 week or more those symptoms. With hypomania, you need only 4 days or more. The mood and the activity level is very similar. All those symptoms we talked about, very similar, but it's the severity that's different. And the big severity is that big thing is manic can get quite psychotic, and hypomanic means that there's a clear change from their usual functioning. Others can notice this change, but they don't actually have to be hospitalized. And then, of course, there's all kinds of stuff we need to, just clearing the drawings. And then there's things we obviously need to exclude. So there's also always specifiers in the DSM. There's something called rapid cycling. Again, we're not yet talking about diagnosis. We're talking about episodes. So in 1 year, if they've had at least 4 of these episodes, one would call that rapid cycling. So it'll be a specifier in terms of the episodes, and some of it might even be in a particular season. So let's talk about bipolar disorder. And now we're going to use our understanding of the episodes to actually put together the diagnosis. So how do we put this all together to decide that somebody is suffering from bipolar disorder? And there's different ways in how it might present. So their first episode, you might not always realize that they've got bipolar disorder, especially if the first episode is a depression. If the first episode is mania, that's easy. First episode is hypomania, not always so easy because people don't necessarily bring them to the hospital, but they might also have mixed mood symptoms when they come in. Sometimes they just come in floridly psychotic, and it's quite difficult because they're so psychotic to realize that they're also actually manic. Sometimes you've got a patient with depression and you've been treating with them depression, and they're just not treatment resistant, and they're just not getting better and just not responding to your treatment. And that might actually be a bipolar patient. But more often as well, especially in your district hospitals, you might meet the patient for the first time because of some disturbed behavior and things that's been happening out in the community. Might even have been happening for a little while. Or they come in because of massive polysubstance abuse. And so quite often they get admitted to your hospital under possible schizophrenia, or people are suspecting a substance abuse disorder. And so quite often bipolar can get missed within all these different presentations. So interestingly enough, women, quite often their first episode that they will present with is a depression, also because women are more likely to come in if they do get depressed. But quite often the first time you'll see a man with bipolar disorder is usually due to disruptive behavior that they get brought in for. So for diagnostic requirements, this is a brief summary, and then we'll go through the DSM for each of these. So for bipolar 1, so there's 2 bipolar disorders. There's bipolar 1 and there's bipolar 2. To be able to be called bipolar 1, you must have had 1 manic episode. Fine, don't need anything else. Most of them would have already had a depressive episode, but they might not even have been seen for it. But a single manic episode classifies you as bipolar 1 disorder. Bipolar 2 disorder is a little bit more fiddly. You have to have at least 1 hypomanic episode, as we've defined it, but they must also have been at least 1 major depressive episode. So if you meet somebody for the first time with hypomania, you might diagnose him with a hypomanic episode, but if there's been no previous depression, you might just observe and keep an eye on that person. And it's only if they develop depression that you might then make that diagnosis for bipolar 2. There's also something called cyclothymic disorder, which I think does not get diagnosed very often and is probably quite often missed. What's interesting about cyclothymia, it's a little bit a bipolar light, so they don't quite meet the full episode criteria, but typical about cyclothymics is that the mood swings quite a lot. So it's not like the same pattern as bipolar, but it's also less severe. Important, we do also have substance-induced bipolar disorder, and that is when they use particular alcohol or particular substances, it actually causes mania or hypomanic symptoms. And then you can also get bipolar that could be triggered by another medical condition, for example, some strange brain tumor or something like that. But those are very, very uncommon. So when you do your assessment, there's 2 things that are helpful. You first need to classify your current episode, right? And I'm going to show you the scale at the moment. There's something called the Young Mania Rating Scale, named after a person young. And you want to be able to define, is this mania or is it hypomania? And then if they're depressive, you obviously want to define that major depressive episode. And there for you, again, PHQ-9, for those of you who's like, what? Please go and look it up. On the Rudasa pages, the mental health pages, you will find a link to my PHQ-9 tool, which has got both the English and the Xhosa translation. Apologies for those of you that are not in the Eastern Cape. So you're going to use your Young Mania Rating Scale to rate the level of the mania and hypomania. You're going to use your PHQ-9 to rate your major depression. And this for me is it's called the clever bit, right? You want to make a diagnosis, you have to be able to understand the history. And there's a great thing called the Mood Disorder Questionnaire. And this is very helpful with somebody who's had a first presentation of a major depressive episode. And you are wondering, could they have had a manic or hypomanic episode in the past that we might have missed? Very important if they do have mania or psychosis to please also do a full delirium screen on those patients, because of course those can also, various medical conditions can also confuse the picture. But yeah, here's the Young Mania Rating Scale. You can see there is 11 questions, and then there's a score, and a nice way to sort of understand whether it's minimal symptoms, mild, moderate, or severe mania. And you can see it's a very nice way to just assess the patient as they are at the moment and to classify exactly how manic they are. And it's also great for following up. So if you're managing somebody with a manic episode in your hospital, or especially a hypomanic episode, like unclear on exactly how high they are, this could be a good way to also help monitor how those symptoms are doing. The mood disorder questionnaire, I think, is really, really helpful and something that we should use much more often. It's got 5 questions. When you look at question number 1, you need to get at least, you'll see there are 13 items, and you need to get at least 7 of these items. So what you're asking the patient is, has there ever been a period of time when you were not your usual self? And then you can see these are all different questions about things like self-confidence, being talkative, thoughts racing, energy, active, etc., etc. So you tick. If you tick 7 or more, and you go to question number 2, you'll see, have several of these ever happened during the same period of time? So this helps you to open a conversation about, did you find all of this was going on at a specific time? And then you can ask and find out more about that. If there is such a time, then you actually want to know what was the impact of that episode on their lives. And if they score, so you have to score 7 out of number 1, you have to score yes for number 2. And then for number 3, if you've got a moderate or a serious problem, if this caused you quite a bit of problems, that's enough to make you strongly suspect that this patient has had a manic or hypomanic episode in the past, and therefore potentially will be defined as bipolar disorder. The last 2 questions is just to look at genetic predisposition potentially, and whether somebody has actually diagnosed them with it already in the past. So to be able to define, so these are our definitions of what do we mean by bipolar disorder. 1, very simple. As I said, 1 manic episode for more than 1 week. To be able to call it a new manic episode, they have to have gone from either one to the other. So they were depressed and now they're manic. If they were manic and then they got a bit better and now they're still manic again, there needs to have been at least 2 months in between where they were completely fine, to be able to say, okay, this is now a new manic episode and not just a manic episode that's sort of been fluctuating over a period of time. You obviously need to make sure that there's no substances or other medical conditions that attributes to it. And that gets really tricky. You can see there, it looks like alcohol addiction disorder can be as high as 30% in patients with bipolar illness. So very difficult to untangle sometimes. And then men, tends to start with their first one as a manic episode. So in terms of how does bipolar behave? So men quite often will come in with a manic episode, but later there will definitely be more major depressive episodes and additional manic ones. But you do sometimes have also more in men where they might have a depression, and then later on they have just these recurrent manic episodes following that. So there's different progressions for different people. For bipolar 2 disease, remember we said never psychosis. So now we want to see this recurrent pattern, and you're going to have very clear there was definitely a major depressive episode, and there's interspersed with those definite hypomanic episodes. So these mood episodes may arise spontaneously, but what sometimes happens is they present with depression. You put them on some fluoxetine for their depression, and actually that triggers them into a hypomanic episode. The bipolar 2 especially can have quite a high rate of rapid cycling. Remember, we talked about those specifiers where within 1 year they can have 3 or 4 episodes moving between depression, hypomania, depression, hypomania, which can be very, very disruptive. It's not quite that common, but we also don't know if it's perhaps because we're just not diagnosing it enough. But there's some things to keep in mind. Firstly, high risk in our peripartum women. So peripartum itself can precipitate it. So especially if you've got a woman known with bipolar 2 and she's pregnant, you need to watch out for that. Many can have anxiety and substance use disorders. So in women, you might have eating disorders associated with it. And if for bipolar 2, 10% of those might eventually end up having a proper manic episode and will be moved on to a bipolar 1 diagnosis. Bipolar 2, you actually may be ill for longer when you have the episodes, although the episodes are not so severe. They do go on for much longer, like the hypomania. And you might be much longer periods of depression as well than in the bipolar ones. And this makes this particularly risky for suicide. So bipolar, of all the chronic mental health conditions, has got the highest suicide rate. And there's probably different reasons for that, partly also because people can be very, very highly functional. But one of the big challenges is that obviously during the hypomania or the mania, you have this loss of judgment. You might make decisions or do things that you now have to deal with the consequences. So if you've spent all your money when you were in a hypomanic phase, when you're in a depressed phase, you now have to deal with what you have actually done. And then, of course, with the depression and everything together with that, that can lead to extraordinary feelings of shame and despondency, and then therefore a very high risk of suicide. Bipolar has also got the highest risk to marriages, so highest divorce rate of all the chronic mental illnesses. And I think the lack of insight makes it particularly difficult. So while somebody is high, they might make these decisions that's going to affect the whole family, and you'd find it very difficult to negotiate with them, and they're very unwilling, obviously, to take treatment because they feel so well. So a very, very hard illness to live with. So this is just a summary of what we've just told you. You guys are starting to get confident in this language. You've got bipolar 1, bipolar 2. Bipolar 1, you only need that one manic episode. Bipolar 2, we want at least one hypomanic episode and one major depressive episode. So cyclothymic disorder, I wonder how much of this we miss. These will be people in the sort of, especially in your rural areas, they'll be seen as quite eccentric. They'll be seen as quite interesting. They might give the mother gray hair, but they might not necessarily come to hospital. It is very much also genetic, so it's going to begin in adolescence and early childhood, and because it's often also with substances, people can think it's part of these sort of young disruptive behavior, and it can be quite insidious. So it slowly builds up. It's very persistent, and usually the only time you might obviously see them is during the depressive phase. They're not going to come during the higher phase. There's quite a high chance that they might eventually develop bipolar, so it might just be an introductory phase. And basically, they are either chronically elated or depressed. So they almost don't do the neutral line, but they're not completely hypomanic. They're not completely major depressive. They don't meet all the boxes. And then they've got this quite rapid cycling. And you can even have some people who shift almost every single day. You can have some people who are in one episode and then shift for 2 days and then go back to being depressed, for example. Presentations can be very mixed. And so these are people that you would describe as somebody who's got a very labile mood, or very labile emotionally. So they've got these various criterion. I think if you're suspecting cyclothymia, if you can't find a psychiatrist, you can actually send the person to. This might be useful to actually speak to a psychiatrist or see if you can access a psychologist to help you actually make this diagnosis, because you'll need to really look at your history to understand what's happening. But you can see you want at least 2 years to be able to make this diagnosis with all these numerous periods. And they must be not without symptoms for more than 2 months at a time. So this is a very chronic cycling of these different episodes. They mustn't have mania or hypomania. And obviously you want to make sure there's no other condition that might be explaining this better. So there's also specifiers. There's various specifiers, obviously, with all the psychiatric conditions, but this specifier I think is quite important. And this is somebody who has bipolar disorder, and the specifier is with anxiety distress. And the reason why this specifier is important is because it's specifically associated with a higher suicide risk. So this is somebody who, during their time where they've had mania, hypomania, or depression, it doesn't matter which episode they were in, but they have 2 of at least the following. So being either very keyed up or tense, being very restless, having difficulty concentrating, fearing that something awful is going to happen, feeling that they're going to lose control. And this is something that wants to ring bells in terms of this person is potentially very much at risk for suicide. And it's usually a very spontaneous decision. Also under specifiers is to actually then set on how severe it is. So if you are going to say with anxiety distress, they've got 2 symptoms, you're going to classify it as mild, moderate, severe, or severe. So just something to keep aware of. Fine. Okay. So the management of bipolar disorder, there's actually a very good, very detailed dissection in your EML. And I'm just going to run you through the EML management. So they've got beautiful tables and algorithms that you can work through. It's too much information on my slides. You're going to leave here and go, oh gosh, that's a lot. All I want you to know is that this exists. And when you have a bipolar patient, go and fetch your EML and manage them according to the EML. There's very nice, clear guidance. So some of your general measures, very much, of course, individualize your management according to your patient, manage all those comorbid medical illnesses. Very, very important. You've got to look for other psychiatric conditions. Remember, there's quite a bit of overlap. You've got to look for substance abuse. Very important to screen for suicide risk and look for that anxiety distress. The most important part of managing chronic mental disorders in general is psychoeducation. But in bipolar, this becomes this is almost like the key part of your care. And the psychoeducation is not only for the patient, but also for the family and the carers. And this is about explaining what bipolar is, explaining the need for treatment. The monitoring for the patient and the family to be able to monitor it is very important. They need to know when there is going to be a problem. And they need to know what are the early signs of possible relapse so they can bring them in earlier than later. We want to talk about things like the need for structure and routine, and to talk about stuff like, well, who do you want to make decisions for you if you are an acute episode to protect you from yourself. I once had a patient. I worked for 2 years in psychiatry in the UK, and we had in my psychiatric hospital where I worked, we had a mother and baby unit for women with postpartum depression. And I had one patient who she only got postpartum mania. And what happened with both her first and her second baby, and she was pregnant with her third baby. And she came in, and she was a sort of a really masculine presenting engineer, very no-nonsense lady. And we had this real discussion around what might happen if she goes high. And she realized from her previous episodes that she had no insight. You know, she can hardly, it's all very murky for her. And she understands that she was manic, but she had no insight at the time. And so she actually signed a contract. We got her to sign a contract with her husband that if he said to her that she had to come in for treatment, she would listen to him and she would not argue. So we had this lovely meeting, and then a few months later, he brought her in, and I'll never forget, she came in and she had this bright makeup on, like lipstick all over her lips and huge red and blue on the eyes, and she was wearing this weird, strange, extravagant outfit, and was explaining to me that she was definitely not high and there was nothing wrong with her, but she's got this contract, and so she has come in as her husband has decided that it's time. And for me, that was very powerful to see how we can actually help patients prepare and negotiate and actually make those kinds of decisions beforehand. There are some great support groups. This actually website comes directly out of the EML. It's very important to see if one can get people to actually help families who's looking after people with bipolar. And for me, the rehab team is extremely important. So your rehab team needs to look at your social worker, your occupational therapist, how are people managing in the workplace, how are they managing in their lives, and to be able to address psychosocial stresses, disability, etc. This is just to show you the World Health Organization disability assessment. And this is something that your social worker can help you with, or your OT can help you with, to be able to see how's my patient managing and how can we help maximize their functionality. Very key in terms of your management of patients. But then, of course, drugs. It's all about drugs. This is very much a neurotransmitter issue. And oral medicines is where we want to go. We're trying to stay away from anything injectable. And this is sort of from best to not so best. And lithium is by far amazing against all of the different types of episodes. And it's been linked to reduced risk of suicide and self-harm. And that is our first recommendation also in our EML. Valproate, a good second option, especially with mania, as well as olanzapine. But you'll see lamotrigine we use more often where there's hypomania and depression. I'm going to go through all of that. And then we have quetiapine and carbamazepine lower down the line. We'll go through this in detail. So how do we prescribe lithium? It'd be interesting to know how many of you out there in the districts actually do prescribe lithium, or if any of you actually have prescribed lithium. Sometimes people, I don't actually know how good access is. That would be something that we can discuss at the end. But in the EML, this is what's recommended. And it can take a good week to work for mania, and you're actually going to treat both the acute episode for it, and it's also going to help you for the recurrence. And look, at lithium is also a treatment for the depressive part of bipolar, but it takes much longer to work. So a good 6 to 8 weeks to treat a major depressive episode. In terms of preventing future episodes, it can see it's good, but not perfect at preventing future manic episodes. Not as good as preventing future depressive episodes, but it definitely reduces overall aggression, self-harm, and suicide. So when you're going to prescribe lithium, you have to do lithium levels. And so your monitoring of the lithium and understanding how the levels work is a key part. And that's what I'm saying, go back to your EML. And you can see we're going to go for slightly higher therapeutic levels in acute mania. And there are different levels that you're going to target for prevention of mania or depression, depending on what your patient's individualized plan looks like. You can get toxic even in the therapeutic range, so it's important to look at the symptoms more than just the levels. And if you're going to take the lithium off for whatever reason, you just got to be careful. And this is where loss to follow-up might be an issue. Now the patient feels really well, they stop their treatment. And if you stop it very abruptly, then that might precipitate another manic attack, which is problematic. So there's various possible adverse effects, which so nephrogenic diabetes insipidus, they become very thirsty, some various kidney stuffs, and the other classic things is either hypothyroidism and hypoparathyroidism, also not that common, but we want to monitor for those, and lithium can cause a tremor, which can be problematic. Toxicity usually occurs when the blood levels are more than 1.2 millimoles per liter and can include like gastrointestinal stuff, muscle stuff, getting drowsy and disorientated, and then, of course, the terrifying seizure, coma, death, but they're always at the end of these. So we want to make sure they don't go toxic. So lithium itself, you can eat what you want, but just don't change dramatically. So you don't want to suddenly go to a low salt diet. Dehydration could be an issue. So some things that can affect the blood salts. And there are some drug interactions like your ACE inhibitors and diuretics and enzymes. So if you're putting patient onto treatment for heart failure or hypertension, for example, and they're on lithium, you might need to keep an eye on those levels. So for patient with chronic kidney dysfunction, we don't quite know enough. So imagine you've got a patient now with bipolar, they've been nice and steady. And now because of their diabetes or their hypertension, they start developing chronic kidney disease. But now there's a high risk if you stop the lithium. So the general rule of thumb is, especially if lithium is not what's caused the problem, is that if you can decide to continue, if you need to continue, do so, or just keep watching those lithium levels because that might change as the kidneys deteriorate. If the patient's got known CKD, you might be able to get away with close renal monitoring, but these kinds of patients you would normally discuss with a consultant. So if your patient now comes in and you've got an acute, so let's start from scratch, right? Your patient comes in for the first time. They either have a mania or they've got a severe depression, which they might either be psychotic with or suicidal. And those patients you have to admit. Your manic patients, almost always this is going to be an assisted or involuntary mental health care admission. And for mania and hypomania, to help manage them usually within the 72-hour ward, you're probably going to need some sedation. Very important is first to obviously investigate, optimize, manage for medical illnesses, look at substance abuse, all the stuff we've already talked about, and then we're going to stabilize the immediate mood. This is actually one of the few conditions where electrovulsive convulsive ECT, shock therapy, is still sometimes used. Not in your district hospitals, please. Send those to the psychiatrist, but there are options if your treatment is not working. And very important is that as soon as you start treatment, you already have to start thinking of your long-term treatment strategy. Okay, so although you can get rid of the manic episode maybe within a week or two, it's going to be about 12 weeks before they're going to be back to full functional recovery. So involve your families, involve the social workers. They might go home before then, but they might not be fully functional yet. So there's various options for the short-term reduction in symptoms, but the EML has got very specific recommendations. for the manic episode. So your short-term sedation, if they're on your ward, lorazepam 2 milligrams 3 times a day, either oral or IM, or you can use clonazepam if you don't have lorazepam available, 2 milligrams twice a day. And you can combine that with a short-term antipsychotic. And if they don't need a lot of sedation, you can even just use risperidone. Typically start with your 2 milligram and you can increase that dosing just once dose at night. And that's quite good just in terms of helping for that initial psychotic symptoms. Very important, you're starting your mood stabilizer at the same time. So you don't first control the psychosis and then put them on lithium. You want to start your lithium on the same day that you're starting your lorazepam and your risperidone. So if you've made a diagnosis of mania, then start. So now, let's imagine the patients come in, you've diagnosed them with mania, you've put them into your 72-hour ward, you're going to put them on lithium. You need to do some baseline tests. That includes the EGFR, your thyroid function test, and the calcium. Remember that hyperparathyroidism. If they've got cardiovascular risk factors, then you can do an ECG, but it's not necessarily indicated. And then the dosing of lithium usually is going to end up being between 260 milligrams just at night. But remember, you're going to use your therapeutic range to get to that right dosing. And you're going to start them with 400 milligrams of lithium. You want to make sure your bloods are all fine. If they're elderly and frail, you might start with a lower dose. And then very important, this is also in the EML, at day 5, you're going to already measure that plasma trough at least 12 hours after the dose. So they actually say on your lab form, write what time. So if you're giving your lithium at night, at least 12 hours, the next morning, 12 hours later, you're going to take your blood and you're going to write on it, this is the time that that the patient was given their lithium. And then notice, so you do it at day 5, you adjust your dosing accordingly. And then 7 days after each dose change, you check the level again. Once your level is at where you want it to be, then you're going to do the level at 1 month. And then after that at 3 months, and then it's going to be 3 monthly. Very important, if your patient also happened to be on treatment for depression, for example, and that triggered this, please taper and discontinue your antidepressants quite quickly. So now just follow this through. Your patient was manic. You put him on lithium. You put them on to get rid of that, to help them with that initial hypomanic period. You've got them onto therapeutic levels, depending on what their levels were. Now the patient, you find the lithium is not working, or it's not tolerated, or they've got kidney problems, there's some issue, then your second line treatment is valproate. So now you can use valproate. Your usual dose is about 400 to 600 milligrams twice a day. So it works out roughly, you're working at around 20 milligrams per kilogram per day in divided dosages. If you don't want to use valproate because your lady is in childbearing age, for example, olanzapine at night is also an option. Not always available, and unfortunately, it does make you very drowsy. Checking there's somebody who's not muted. Let me just sort that out. There we go. So after your manic episode, if the patient now becomes euthemic, manic symptoms is gone now, you can taper and stop that risperidone, definitely get rid of the benzos early on. And now you're going to just check your lithium levels to ensure that they stay in a therapeutic range. If the symptoms are persistent, or your first line and second line hasn't done the trick, then you're going to speak to a psychiatrist, and then clozapine is an option, but let the psychs worry about that. Okay, so that was mania, right? Now imagine we've got a hypomanic patient. So these guys you might often have seen in an outpatient basis. So they've come in, you've realized the patient is hypomanic. They might even have had depressive episodes in the past. You've started them on lithium in exactly the same way as you did with your manic patient. That's going to help for the hypomania. You should not be needing an antipsychotic. And now again, your level, and you can see that therapeutic level is a bit lower than it was for mania. You're going to now keep the patient on the, it's making me give me thumbs up. That's just because I use my hands way too much when I teach, and Zoom is clever. So if lithium is not tolerated or is contraindicated in the hypomanic patient, so say you're not winning with the lithium, then your next option is actually lamotrigine. So that's different than for a manic episode. And quetiapine, again, that will be under your psychs, is another lovely option as well. So just notice that hypomania and mania there is different in terms of your second line options. So your second line option for mania is going to be your sodium valproate for bipolar 1. For bipolar 2, your second option is lamotrigine. Great. So your third scenario is your patient is coming with an acute major depressive episode. You've done your scale, your PHQ-9, and then you did that lovely, remember that mood scale, and you've discovered that this patient has had hypomania episodes, for example, in the past. Again, you're going to check the lithium levels. You're going to put them on lithium just like we did for our patient who came in, our manic or hypomanic patient. Get them onto lithium. You can see the dosing there is different, but this is different. So this patient's we're not going to treat with an antidepressant. What you're going to add to your lamotrigine, to your lithium to treat the depression is you're going to add lamotrigine. So the lithium on its own might not be enough for the depression, and we're going to titrate that to about 200 milligrams noctase, so just a once daily dose of lamotrigine. If the lamotrigine doesn't do the trick or is poorly tolerated, then quetiapine is there, but yes, please speak to your specialist. Don't do quetiapine on your own in your district hospital. If they had to use risperidone or olanzapine for whatever reason, taper those slowly. And you want to make sure your patient's going to stay on something to be able to prevent future manic episodes, depending on how they've tolerated what they're on. So once the patient's euthymic, so they were depressive, you've treated them with their lithium and their lamotrigine, you're going to check the lithium levels and make sure it's in the therapeutic range. And if they continue to have persistent depression and they're just not managing, then again, talk to psychiatrists, and clozapine here might be another option. Just a general rule for all of these patients, don't combine two antipsychotics ideally, and trying to avoid combinations that cause weight gain. So valproate and olanzapine, for example, is not a great combination. So when you monitor your lithium levels and your EGFR, you want to do those every 3 monthly, and you might do it more frequently if they are 6 monthly, but if they've got comorbid conditions or they've got kidney problems, you would do that 3 monthly. And again, just go and look up what levels you're going to target to monitor your patient. And it depends a little bit. So that's what you treat for the acute mania. If they've had a manic episode, you're going to put them on slightly higher levels than if they've recently had a depression episode. You're going to do a TSH and calcium annually. You're going to do a cusp and full blood count 6 monthly. And very important, you want to continually monitor how that mental and physical state is. So remember, I mentioned that lovely Young scale, the Young Mania Rating Scale. You can use that to monitor the level of your symptoms. If they've got depressed, you do your PHQ-9s. Keep on looking at functionality, and you're going to adjust your medication as you need. To discontinue your treatment, the biggest challenge is people do not see the point of taking this stuff long term, especially if it's a hassle in terms of monitoring. Ongoing psychoeducation of the patient and the family is very important, and very important after somebody's had an attack. So say they've had hypomania, it's now 12 weeks later, they've come out of it, to have a proper discussion of everything that's happened and get the patient to reflect on, oh, this is what happened and this is how it's affected my life. If you do decide you're going to discontinue treatment, it's generally not advised, but say somebody wants to fall pregnant, for example, or maybe they're struggling with the medication, you have to at least taper and do it very, very slowly, and have to give them very clear advice on what to watch for in terms of future relapse. But generally, this is not recommended. Do refer if you've got patients who obviously are very high risk to themselves or others, and you don't have the facility to look after them. For patients who are rapid cycling, remember that definition, 4 or more episodes within a year, going up and down, even if they're on treatment, or if they're not responding to your treatment, then you have to get your psychiatrists involved. I'm just looking at time. I'm going to flash through these slides because it's just to highlight a couple of things on bipolar disorder and pregnancy. If you've got a patient with bipolar disorder and pregnancy, you have to get your psychiatrist on board. Oh, the challenge is, I don't think my voice is going to manage this. Just hold on. Apologies. That was a bit of a dramatic cough. Okay. So let me not put my video on, then you won't see my teary eyes. So for bipolar disorder and pregnancy, it's an absolute disaster to get manic or severe depression while you're pregnant or in the postpartum period. Puts the mom at risk, puts the baby at risk. And so there's a huge drive to keep people on their treatment, but most of the treatment we have is not ideal. So bipolar during pregnancy is associated also not just with, oh, you know what? I think I'm not going to manage. Let me be clear. What I'll do is I'll record this little bit and I will load it separately as well so that we have that for future reference. But I can just, I'm just going to sound like a croaky old horse for the next 5 minutes. In the little summary that I'll make, I will just show you all the challenges with using lithium, the challenges with using valproate, obviously, which we don't want to do. Lamotrigine definitely is a good option. And so ideally, you want to actually already think about that before somebody falls pregnant, and very important to not use your benzos at all, if possible, in pregnancy. Some of the antipsychotics is actually an option, but yeah, please just discuss with a psychiatrist. But I'll record this properly somewhere else. Apologies for my voice not making the whole hour. Thank you very much, everybody. That is a summary on bipolar disorder. I'm hoping that gives you a little bit of confidence to actually manage bipolar in your own facilities, and identifying it more regularly and providing good long-term care. I'm very happy now to open this for some questions and discussion. I'm particularly interested to hear about the availability of drugs like lithium in the district hospitals. You're welcome to either put a hand up or put something in the chat. Oh, thanks, Steph. There's also a poll that just come out. Please use the poll so we can see how useful this was and also check attendance. Gosh, no huge questions. Can I ask, and you can just do this through maybe send a thumbs up. Who of you have prescribed lithium before? Just trying to get an idea of how much we actually... Does anybody here know whether we have lithium in the district hospitals? Jenny, please go ahead. Yes.
Madeleine, and colleagues, thanks very much. I was just sitting here thinking you make mental health sound very easy. So thank you for these slides and presentation. Madeleine, there's not a lot of lithium around. I'm talking sort of Eastern Cape side in the district hospitals. I think generally what I'm seeing is that when a patient has been seen at a mental health unit, which in our case is usually CMH or MTATA, it seems that as soon as a patient is going to be discharged or sent back to the periphery, they rather use Epilim. So I don't see a lot of lithium being prescribed. I sometimes see lithium has been used, and then so I use lithium when I was in KZN, but I don't see a lot of it here in the Eastern Cape. I think perhaps people who are around tertiary and regional hospitals where it's easy for them to go back, but I don't think it's being used a lot. I mainly see patients on Epilim as a mood stabilizer.
Because it's also interesting because lithium, Epilim is a good option for patients who had mania, but it's not actually the preferred options for patients who's had hypomania, where one would actually choose lamotrigine. And I've got a hunch we just don't diagnose bipolar 2 very often at all. And there's probably a significant number of bipolar 2 people in our communities who struggle with functionality. And I think that's where that mania rating scale might be a really interesting thing to do if you've got patients with depression who's got major functional issues or behavioral issues, to do your mania rating scale and just, well, hold on, maybe there is actually something like that that might be tripping them up. Because I see that also with the major psychiatric units, the only people, I'm currently running the 72-hour unit at CMH. I've taken over G4 this year. And certainly by the time they come to CMH, they are definitely very psychotic. And if they are manic, they are very manic. We do not see any of the milder presentations coming to the psychiatric hospitals. So that all ends up then, the burden to see them and find them is in the district hospital setting. I don't know if any of the other provinces has had experiences in terms of lithium access. Okay, that looks... We are on an hour, and I do like to be on time. Thank you very much, everybody, for attending. Apologies this week a little bit with our scheduling hiccup, but life happens. And we will get back on board. So from next week, it will usually be on a Tuesday evening. We'll just double check with our speaker that was going to be yesterday, if it will be next week or the week after. But the next two presentations will be Dr. Mandondo, who's our wonderful, extraordinary DCST obstetrician. He's going to come and talk to us about bleeding, vaginal bleeding in women. So we're going to have a bit of a gynae topic, which is very nice for a change. And then we will also talk about how you manage heart failure without without sonar machines, without echoes. And we have Dr. Moketsi is lined up for that. But we'll keep you posted on when exactly that is going to happen.
Okay. Madeleine, there's one question in the chat.
So interested from other colleagues under which unit in their respective hospitals of the 72-hour. Okay. Thank you, Zenande. So that's our social worker from CMH. So what Zenande is asking is particularly around, so for example, in family, there's 3 possible departments in our regional hospital setting that might run 72 hours. It can be either internal medicine, or it can be psychiatry, or it can be family medicine. Quite often it ends up being internal medicine, because the purpose of 72 hours is to identify whether it's a psychiatric disorder or a medical disorder. And so a big part of the 72 hours is the medical workup, which the psychiatrists generally do not get involved with. So traditionally, quite often it falls under, if you're in a big regional hospital, under internal medicine. But of course, in the districts, it always is your family physicians or falling under your sort of district hospital medical officers who looks after those units. So I don't know if anybody else wants to add if they have a particular different thing that's happening in their areas. But at CMH, we've just switched over that internal medicine is now handed over to family medicine, and we're very happy to be running the 72-hour unit at Cecilia Makiwane Regional Hospital here in the Eastern Cape. Oh, so that's quite a nice question, Lauren. To be quite honest, I'm not offhand sure. As far as I know, what it says in the EML is they need to be on some sort of mood stabilizer, but of course, lamotrigine in itself is a mood stabilizer. I would discuss that with one of the psychiatrists. I don't know if anybody, I don't know, we probably won't have psychs on this call. But yeah, I'm not 100% sure, because you're right, lithium is usually not available. My hunch is we're probably just going to use the lamotrigine. Very important while I think of it is if they have been on fluoxetine or an antidepressant, you need to wean them off that antidepressant. So we do not want them on an antidepressant if their major depressive or disorder has a history of mania or hypomania. I've got a hunch it's just going to be the lamotrigine on its own, but please do check that with a cleverer person than me. Okay, great. Thank you very much, everybody. Have a lovely evening, and we will see you guys next week. And I'm not going to promise to post that resource tomorrow, but before the end of the week, I will send out the resource on mental health.